Comrade Chiza. I don't know if I'm audible enough. Bear with me. I'm still in my department, but there is some background noise. First and foremost, I apologize. The previous session did take place. These IT issues sometimes can let us down, but thankfully, and we hope today all goes well. Like we have given the introduction, most of the trauma cases are referred for other imaging modalities, X-ray, CT, and MRI, and other things. But in this case, we want to see the value of MSK in ultrasound, in trauma. Again, my name is Vitus, Bassimwa A. I'm an imaging technologist, a specialist. Go in and see. MSK ultrasound. Sorry, I was saying ultrasound has high sensitivity and specificity, especially considering to some of these other imaging modalities, whereby MRI is predominant, the reference standard for musculoskeletal or soft tissues because of its high resolution and image sharpness, and because it is multiplanar, can have your images in sagittal, coronal, and axial. But ultrasound has exhibited a good high sensitivity and specificity in relation to MRI. Why do we want MRI, ultrasound in the assessment of trauma? It has good dynamic maneuvers. We know ultrasound is real time. This gives us good maneuvers to take our patients in real time and with good maneuvers. Ultrasound gives fidelity that will give you this kind of assessment over the area of tenderness to be positioned in one particular ultrasound. We have flexible pressure over the area of tenderness. And you can compare to the other side that is not sick. That is if you want to differentiate the normal from the abnormal. And then if you are doing rehabilitation, you do short time interval follow-ups because ultrasound is cheap and it is readily, it is mobile, it is affordable. So you can follow up. And then with ultrasound, no contraindications. Unlike MRI, if you have metallic implants, you won't be able to proceed. Then, like we said, it's mobile. You can do it bedside. You can go out to the fields, especially the sports grounds, for those who are interested in sports medicine. And it's cost effective, it's cheap and easy. But If you want to do musculoskeletal ultrasound, the type of equipment that you use matters. I want to give a disclaimer. I don't represent any of the companies in any of these images, but these images are to emphasize the quality of equipment you use. If you look at this ultrasound machine, this would give you suboptimal 4 compared to this Mindre type here, and many of the other different types. So make sure you have a good machine with good resolution. We'll see the contents of what we are looking for in MSK. These are the probes that we use in MSK. We have the hockey stick, we have the usual linear, and at times we use the curvilinear, especially for the hip. The hip has bulky muscles that the linear or the hockey stick cannot afford, or because of the high frequency the penetration is reduced. The linear, because of the low frequency, the penetration is much better. So when we are doing MSK, especially in trauma, what is our interest? Our interest in MSK, first and foremost, our interest is in the muscles, the fascia. The fascia is the coverings of the muscles, anterior and posterior, and then the aponeurosis. And what we look for here is tears in any of these, either muscle tear or a tear in the fascia or in the aponeurosis. Then we look at the tendons and ligaments. We look for tears. Then we look at the insertion. Usually in trauma, you will get avulsion fractures, especially at the insertion. We look at the synovium for hypertrophy or for inflammation. We look at the joint capsule. Then we look at the articular cartilage and the meniscus or the menisci, especially within the knee. Then we look at the fat pads, where there are fat pads, especially in the knee, in the elbow. We look at if these fat pads are floating, in the accumulation or collection, if they're floating or if they're displaced. These are some of the signs that will show you or will depict you there's some existing pathology because of trauma. Then in bone, you have cortical disruptions or you have break in the cortex, especially when you have fractures, or you have peeling or avulsion. Some of these are not demonstrable in the X-ray because of the way how this beam is tangential to the these injuries. But ultrasound, we all know you can rock your probe to the left, to the right, you can do oblique, you can heel and toe until you, it is really good and easier. Then for the joint recesses or the bursa, look for hemorrhage or any effusions. Not all fluid collection is hemorrhage or is effusion. It depends on the type of injury, like we'll see some of the examples. And then we look at the nerves. Now, particularly for this one, especially for the humerus, if you want, the most affected is the radial nerve. If you have a mid-humeral fracture, usually nerve, or when they put in metal implants post-surgical, many of those screws, they are long, and sometimes surgeons, don't take notice, and these screws go through and they're impinging on the nerves, and they're also pinching on the muscles. So in musculoskeletal ultrasound, especially in trauma, we have to pay attention to all of this. Now, MSK ultrasound is very funny. We have to take note of the mechanism of injury. The mechanism of the injury, you can easily use it to tell, is it the ligament, the tendon, or the muscles affected? Whenever you get a patient with injuries, musculoskeletal injuries, first and foremost, do a physical examination and take note of the mechanism of the injury. Let's say it's an ankle sprain or twisting. Was it medially twisted or laterally twisted? That will give you a clue of what particular ligaments or tendons or muscles to look for. I want to give an example. The last MSK presentation by Mr. Cuthbert about the Achilles tendon. If you want to know the complete tear of the Achilles tendon, and you do the Thompson test, whereby you compress the calf muscles, especially the gastrocnemius and the soleus, with an elevated leg, and the foot is not pulled along, then you can clinically say there is a complete rupture. So, but you can't be sure unless you go to imaging. So do physical assessment before you can start your ultrasound, so that you get to know the mechanism of the injury. It helps you. Then the ultrasound findings will depend on when was the onset of this injury. Is it 24 hours ago? Is it 3 weeks ago? Is it just 1 hour ago? The timing also matters, because the timing affects the appearance. Those of you who remember splenic hemorrhage, or we know what hemolysis does. Fresh hemorrhage has weeks or more. So timing and the onset of the injury matters on the findings you're going to get. Then the technique and the maneuvers applied. Like we say, that ultrasound has good maneuvers compared to the rest of the imaging modalities. You will find that some of these tendons or ligaments, you need maneuvers to demonstrate them. For example, the fibrotalar ligament. You'll find that ultrasound is somewhat better than MRI, because in ultrasound we employ in maneuvers, and it gives us a better demonstration. And then we have to take note of anisotropy, which is the biggest artifact in musculoskeletal ultrasound. How your beam meets your target. Sometimes this anisotropy causes a lot of pathologies which don't exist, or it can mask pathology. But also, anisotropy is good, like we'll see some of these cases. Then image acquisition techniques. We have panoramic imaging, especially if you want to follow up some of these ligaments and tendons, for example, the quadriceps femoris tendon, along with the patellar tendon. You can do panoramic imaging, and we have to employ both short axis and long axis. Don't only go by one plane. If you go by one plane, like we'll see, you'll miss some of these pathologies. So the probes employed in the hockey stick probes and tendons, it has good resolution and is able to demonstrate. If you want to do musculoskeletal ultrasound, it's not like where you go for the liver and then you can easily pick it up. So you need some good technique or some good hands. on. It's good you have good hands on. We are going to delve into these cases do not have trauma, but this is just to highlight how much we need to think of musculoskeletal ultrasound in trauma. First and foremost, we are going to look at the shoulder. This is the anterior view, and this is the posterior. We have the subscapularis muscle here, and its tendon over there. We have the supraspinatus and its tendon. Then on posterior, we have the infraspinatus and its tendon, and then the teres minor and its tendon. But like you can see, these tendons are broad. In most cases, when we put our probes, we tend to centralize our probes. But it's imperative you move the probe to the entire width of the tendon, because there can be a tear anywhere. It can be superior here, it can be inferior, anywhere. So scan and move through the entire tendon or the entire ligament in its entirety. But this calls for you to have anatomy at your fingertips. So the first case here, this was a 43-year-old male. He was preparing a meal, and then he had boiled some hot oil, dropped in onions, throwing in onions, the oil sudden withdrawal of his arm, and he felt sharp pain in the shoulder. He did medication, self-medication, usually with the painkillers. Excuse me. But this man went to the gym, and as soon as he went to the gym and started lifting heavy weights, again the same pain came back. And shortly he came to our department, and this is what we found out. This was a shoulder scan. By the technique or by the protocol, we usually start by looking at the biceps tendon. Now, this is the biceps tendon in the transverse or in the axial plane. This hyperechogenic thing here. And then this hyperechoic, this is fluid collection within the sheath, tendon sheath of the biceps tendon. And we know it moves through a groove. So it gives a potential space for this fluid collection, which is also demonstrable right here. This hyperechoic, this is fluid collection, and the rest of this is the tendon. Now, what happens when you have any rotator cuff tear, you'll have fluid collection in the tendon sheath of the biceps. You'll have fluid collection in the subdeltoid, subacromial bursa, and you will have tear or irregularities within the bursa. So at first, because this is our first image protocol, you will see this fluid collection within the tendon sheath of the biceps. But this was an actual tear of the supraspinatus tendon. This is the supraspinatus tendon, and like we can see here, there's this hyperechoic defect separating these two ends of the tendon. You can see this irregularity and this serration here. This was a complete tear of the supraspinatus tendon. You can see there is loss of volume. We have this irregularity because we know this supraspinatus tendon inserts at the greater tubercle. But at this greater tubercle, we have this bone irregularity. So when you have a tear, you have a break in the fibrillar pattern of the tendon. You have fluid collection. You have loss of volume. And at times the tendon, the portion that is from the insertion, just like you can see here, this gap is created because there is possibly, this could be hemorrhage, and this other proximal portion, the one that is proximal to the muscle, is retracting away, and you can see more of this. It is giving us this Y shape. Now, sometimes When there is complete retraction of the tendon, you find the bursa. This is the bursa here. This is the deltoid muscle, and here is the bursa. At this level, we didn't demonstrate the fluid correction, but at times we find this bursa is in contact to this bony surface of the humeral head. Because this humeral head has been opened up, there is free space, there is loss of volume, and the bursa falls in up to touch the cortex of the humeral head. Just like you can see here, this was a complete or full thickness tear of the supraspinatus tendon. You can delve into the different types of tears, partial, full thickness. It can be to the bursa side or the entire tendon, or it can be towards the bony side. The second case is an elbow. Now for the elbow, we usually use features or signs that are going to indicate to you there is something wrong. I particularly put this image, one particular interest, one in these fat pads. There's this one which is anterior, and there's this one which is posterior. But you can see the potential spaces in there. These potential spaces open up to the joints space, both anteriorly and posteriorly. This is our olecranon fossa. And then we have another potential space here. This is a bursa here. But these fat pads, in most cases, will give us a sign there is something wrong. You may not see a fracture or a tendon tear that is so direct. But if you find, for example, if you find any of these fat pads displaced out of their place or their insertion, then it is a sign that something is wrong. Let's go to an example. So this is an elbow. We are looking at the posterior aspect of it. This is a fat pad, this triangular hyperechogenic thing here. This is a fat pad here. And you can see it makes a very good, almost a perpendicular angle with a distal humerus. In X-ray, we look for the sail sign. That's why I put this thing here, this image here. This triangular sail sign here. It should be, we know how a triangle is, or the shape of a triangle. And this one rightly gives us a very good, perfect triangle compared to this. But when you look at this, this fat pad is tracking along the posterior cortex of the humerus. You see it is elongating. It actually, we can't finish it here. It is moving superiorly compared to this that is in normal positioning. So this was a fat pad tracking along. So we have lost the sail sign here. Immediately you see such, it should be an alert. There is something not okay in this elbow. Of course, this is after surveying the rest of the anterior, the lateral, and the medial side. But when we come here, we see there is fluid correction. And it is this fluid that is displacing away this fat pad. Now this fluid, this was hemorrhage. This was a 36-year-old male, a 37-year-old male who had fallen down from a motorcycle. An X-ray was done, but it was normal. We know an X-ray cannot demonstrate hemorrhage, but there's a study which was done, and it showed when you have hemorrhage, more than 70 to 80% is an equivalent of a fracture. It might be so small that you cannot clearly discern it apart from doing MRI, but once you see hemarthrosis and you have fat pad displacement, most likely you have a fracture. It might be tiny, but it changes management of such injuries. So on X-ray, if you are keen enough, this sail sign may actually also be lost. That is actually the previous or the old mode, how X-rays used to be interpreted. But thankfully we have ultrasound, high frequency, is a maneuverability and cheap. It is here to help us. Next is a wrist. I believe we can all see this is cortical irregularity. This was a wrist. This was a 57-year-old who had an accident. After about 6 days, his wrist was swollen. I personally did the X-ray and it was normal, and I was persuaded to do this ultrasound. And you can clearly see there's multiple fragments within the distal radius. There's cortical irregularity, or you can call this is giving us a ladder. You can call it the ladder step sign. If you are ascending upstairs, you are ascending against ladders. This is cortical irregularity. Now, at the beginning, I said this depends on how you do the X-ray. Now, the way the beam met this fracture could not demonstrate it. We are used to that anterior posterior or posterior anterior and the lateral or the oblique. But sometimes they will not give you anything. You will just see something normal, but you see the hand is swollen. Be tempted, go and do an MSK, and you will clearly demonstrate this is a fracture. Only demonstrating this changes the patient management. And if you ignore this, especially for the young adolescents, you're going to leave this person disabled. So once you have trauma and your X-ray is showing normal, please, unless you can do MRI that can reconstruct in different planes, do an ultrasound. But we know the cost of an MRI is not something you can easily utilize, especially for our low-income countries. So ultrasound is cheap. Let's go for it. Next is a case from the knee. Again, from the knee here, I want to appreciate some of the signs that will tell you something is not right. We have our femur here, we have our tibia, we have our patella here. We have our suprapatellar fat pad and our prefemoral fat pad here. Then we have our Kaga's fat pad here. Now, this is a potential space, the suprapatellar recess or bursa. But even here within the Kaga's fat pad, you can see the potential spaces. Now, in most cases, what happens when you have a tear of this is the anterior cruciate ligament. Ultrasound is very poor in depicting the cruciate ligaments. But if it is the easiest imaging modality you have, you can easily tell there is a tear of the anterior cruciate ligament. If you have this fat pad either displaced more superiorly or inferiorly, because there will be hemorrhage within the joint and it displaces this fat pad either inferiorly or superiorly. The same thing, if you have hemorrhage, in most cases, it will go to the suprapatellar recess. Like this example here, this was a 19-year-old who twisted his knee during a basketball match. There is some fluid collection here. This is the suprapatellar fat pad. This is the prefemoral fat pad, and this is our quadriceps femoris tendon complex. This is the actual image. There was some significant fluid. Sometimes you may find little fluid, but you have to determine its significance. And this was 5 days after that injury. But this fluid was still persistent. And like we say, to the normal side, this fluid was significant. Like I said, once you find hemarthrosis, 70 to 80%, there's a chance of a small fracture, or there could be a ligament tear. It may not be so pronounced that you will demonstrate it unless you do MRI, but you are going to aid management of this patient. And this patient was put to bed rest with an immobilized knee. And 4 to 7 days later, he came back. When the cast was removed, he was relatively okay with maneuvers of his knee. Then this image down here, this was a 60-year-old who fell down. This was a fracture about 2 months old. We can see this is a fragment of the patella. There are 2 fragments here, this one and this one. And this was fluid correction. Possibly this was a hemorrhage which has undergone hemolysis, but we can see this is a Kaga's fat pad and it's displaced. And we said once you find fat pad displacement and then you have this fracture, this lady So this old woman most likely also had anterior cruciate ligament, complete or full thickness tear. And she was unable to, she could not stand on this leg or because the knee could not support her weight. The X-ray demonstrated the fracture of the patella, but the X-ray did not actually demonstrate to us by which extent, even on the lateral, until we did this and we're able to see there's fluid collection, which in most cases you might not see on the X-ray. So this is fragment 1, this is fragment 2, this is our Kaga's fat pad, this is the femur, and therein is the fluid collection. But this was 2 months later. This could be hemorrhage post hemolysis. Again with the knee, this was a 39-year-old male. Now this one, he got a knock. This patellar tendon or the infrapatellar tendon, we see some hypercogenicity here at its insertion at the tibial tubercle. But this hypercogenicity is, but this was a fresh injury. Now something I want to alert us here, you have some of these injuries have existed for some long time, but this is recurring injuries. When you look at the transverse, you see this hyperechogenic foci, and then you see this halo. This halo is edema, but some of this hyperechogenic were tendon calcifications, which was an injury that had prolonged. But this hyperechogenicity now is because there is re-injury to this tendon, and this is edema. So what we are looking at, yes, is effects of new injury, but also there is old injury. So there is tendinosis, which was perhaps degenerative or has been on for a long time, but there is fresh injury to the same tendon because this is edematous, and we know edema usually comes with fresh injuries. This was a different male, 35, fortunately in the same sports event. This was a knee. We can appreciate this triangular structure. This is the meniscus on the medial side, because this is our femur, this is our tibia, but we can demonstrate this meniscus here. But when you come to the lateral side, we have lost that triangular shape of our meniscus. Now, this is the very same case. We have loosened areas within this meniscus, and like we can see our femur and tibia, this meniscus is almost out of position, or it's pushing away this iliotibial band. It is ballooning it more laterally. So this was multiple tears. Like you can see all here, there is, usually you may find cystic areas or these hyperechoic areas within the meniscus. Once you find this and there is trauma, this is usually tears within the meniscus. Again, we say that ultrasound gives us signs, but when you do MRI, it can perfectly and much better demonstrate this. But like we said, the cost of MRI is high, but here we have signs that give us what we are looking for. And surgery was done to this young man, and indeed he had bad tear of the lateral meniscus. Thankfully, he's recovering. This is a case I'm following up. Hopefully, when time is given to me, I'll follow up and give the different appearances post-surgical to this. As we finish up towards the leg, this was a 27-year-old, also a young sportsman who had trauma, but kept this injury for about 3 weeks. And he had particular tenderness, medial to the calf, but inferior to the gastrocnemius muscles. And we could find this heterogeneous solid mass. Now, of this muscle injury, this one here is giving us different echogenicities. We have hyperechoic, we have hyperechogenic. If it is a fresh injury, you're able to depict the muscle tears and the tears within the aponeurosis for the fascia perfectly. But this was a tear. Like if I give an example here, this is our in the actual, this is our gastrocnemius muscle. This is our soleus. And our posterior, you can clearly delineate the fascia of these muscles. You can only demonstrate the anterior fascia of the soleus muscle, and you can demonstrate the gastrocnemius muscle. You can't even see the aponeurosis. This was a mass. This was hemorrhage because of the tear. But this young man, like many of the young of us who persist with our injuries, thinking they are going to heal miraculously, but he could not play his soccer anymore because he always had that tenderness. And this here is just to demonstrate this mass that was affecting our soleus muscle and its aponeurosis, and it was somehow also extending to the anterior fascia of the tibialis posterior muscle. Moving down to the ankle, some of these images is to demonstrate to us, we may on an individual basis dig deeper into the anatomy. But what I want to emphasize is this. This was a 52-year-old female who had twisted their foot. Now, in here we have our extensor dictorum longus tendons, but within its sheath, we have this hyperechoic area. This lady, the ankle was swollen. Like you can see here, there is edema. This, the multiple hyperechoic channel, tortuous channels. This was edema. And here, this was fluid correction within the tendon sheath. Like we saw for the biceps tendon, this will give you the appearance of a tenosynovitis. But in actual sense, it is resulting from trauma. And when we went further, these are the peroneal tendons, the peroneal longus and the brevis. And there's fluid collection within also the sheath. Again, this is showing the extent of injury, especially the tendons. And she also had swelling of the big toe, and this was hypertrophy of the synovium, this hyperechoic area here. This is the head of the metatarsal, and this is the base of the proximal phalanx. This synovium here, hyperechoic, is thickened compared to the normal. Of course, like we said, compared to the normal side, so that you can learn what is normal and what is abnormal. So you have a tenosynovitis, the extensor dictorum longus, and also the peroneal tendons, fluid collection in there, and then hypertrophy, also a synovitis. This is the ankle. This is the anterior ankle recess. The anterior ankle recess is given by the distal tibia, which is here, then the dome of the talus and the head of the talus. This depression here, and it is filled by this part. Like you can see here, we can even see this cartilage here. This is our tibia, this is our dome of the talus, and this is the head of the talus. But in this case, we had this 10-year-old who had twisted their ankle. And we can see this hyperechoic defect here, pushing this fat pad away from the head of the talus. There was a small tear at the head of the talus and just a small hemorrhage, but it's worth to bring or to cause enough pain. Like we said in anisotropy, this is our ankle recess demonstrated. But do not be deceived, these hyperechoic areas, that this is injury. This is anisotropy. So be careful, anisotropy can lie to you. Here, this is not injury, this is anisotropy. How your beam is meeting these tissues. But compared to this, this is a defect. And you can see there is mass effect. It is pushing out the fat part. So be aware of anisotropy because it is the biggest artifact in MSK. Going down to the foot, this was another case. This was also a footballer. We have our tibia here and the fibula. Now distally, there is this, what you call the distal tibia anterior fibula ligament. It is a small ligament, but when you look at this ligament is thick. You cannot clearly demonstrate all of this. So it touches from the tibia to the fibula, but this was thick. This was inflammation, and the very same gentleman also had the fibulocalcaneal ligament. Now, if we went into the normal appearances, or if we go into the anatomy, in video we can appreciate some of these ligaments. But you can see also this fibulocalcaneal ligament, which is usually inferior to these peroneal tendons. But you need some maneuvers to clearly demonstrate this. But it is a small tendon, but once you see this kind of thickness, and this echo pattern is not good, or is not the normal appearance, we know the tendon is supposed to have normal continuity of the fibers, and it's supposed to be hyperechogenic, unless there is an isotropy. But this was thickened. Again, this was because of these sports injuries. Now, when we come here, now this is the fibulatalar ligament. I must mention, when there is ankle twisting or most of the ankle injuries in trauma, the most affected ligaments is the tibiofibular ligament, the fibulocalcaneal ligament, and the fibulatalar or talofibular ligaments. Like you can see also this one is thickened. And like you can see along the arteries here, this is just something very small, a very small version. And you can see this cortical irregularity at the talus. This is the doom of the talus, just a small cortical irregularity, and then thickening of the tendon. The same thing here, we have our fibula and our talus here. This tendon is thick. It's not supposed to be of this thickness. Now, I'm not giving a specific size of the thickness for particular reasons that sports athletes and some of us who don't do sports, many of these ligaments and tendons of us might not be of the same thickness, but we consider the body habitus and the clinical presentation of these patients of ours. But again, with more experience in MSK, you can appreciate the normal appearance and you'll be able to discern the abnormal appearance. Last but not least, this was a 43-year-old female. You know, trauma is not restricted to twisting or falling down or something hitting you. This lady was cannulated. Unfortunately, they couldn't get any vasculature within the arm, and they opted for the foot. And the cannulation was at the level of the first metatarsal head. Lo and behold, this lady has hypertrophy of this synovium. Now, this hypertrophy is simply because the cannulation, we know at the start of the cannulation, it's needle guided. So there was trauma to this synovium. That's why it's hyperechoic and thickened. When you compare, this is the right, which is affected and you compare to the left. Here we cannot see this synovium. You can't see this hyperechoic defect. So this is the abnormal appearance, and this is the normal appearance. And this defect was a result because there was trauma and inflammation because of this cannulation. And the foot was swollen. She also had edema. Until we found she had this synovitis. Lastly, this is the head of the fourth metatarsal. We have again cortical break or irregularity here, or our ladder step. There's a fragment here where you see these arrows. There's break in this cortex here. This is small fractures. This lady here had pain persisting for 2 weeks, and the foot was swollen for more 2 weeks. And when we looked at the tendons of the extensor dictorum brevis tendons, you can see how thickened they are, and they are hyperechoic. So the X-ray was done 2 weeks before, it showed normal. And this patient went home, but the pain persisted and the swelling persisted for 2 weeks until we did a scan, and there's a fracture in the head of the fourth metatarsal. So some of these signs might not be direct on some of these other imaging modalities, except these days, CT, we have evolved high resolution, higher slice number, and the reconstruction CT scan, but also CT scan, the radiation there is not what you want. The cost is also relatively higher, but ultrasound, like we have seen, has higher sensitivity and specificity. So from now onwards, if X-ray is not giving you adequate results, ultrasound is a good imaging modality to go and check in, and it will give you unbelievable results. You will see many of the injuries you could not have seen, but the problem with ultrasound, it's operator dependent, and the quality and the type of equipment that you use also matters. In the nutshell, dear comrades, my presentation is just to call on us. Let's be creative. Let's employ all imaging modalities. Ultrasound is a high evolving, and it is developing and changing at a supersonic speed, and it is showing good signs. It's not only left for vascular, echo, abdominal only, but it is actually showing high sensitivity and good specificity in musculoskeletal ultrasound, not only in trauma, but also in other cases, in rheumatology, and many of the other cases. I implore unto you, you can reach out to the experts who have mastered musculoskeletal ultrasound. Reading the books alone will not give you the expertise or what to look for. And this presentation alone may not be enough for you to know what you're looking for. But you can reach out to us, to Radiology Without Borders, or any of us, or someone who's experienced enough in MSK, and we'll guide you. This presentation might not only be for awareness cases, but sooner or later, when you start employing this, you'll see the different results. I thank you very much. I apologize for the glitches in the internet network. I apologize for not having a full presentation previously, and I apologize for the background noise apparent. I thank you very much, but I ask you, embrace musculoskeletal ultrasound. Let's go in, let's enjoy it, and let's discover and let's do research. This is an open area. I thank you and a good evening.